liver cancer is one of those cancers where we know why people get it. It's not like a mystery like maybe pancreas cancer, where most people who get it and can't figure out, other than bad luck, why it happened. But liver cancer happens to people who have liver disease. In the United States, I think our statistics are not quite representative of what happens in the U.S. overall, because we have such a large immigrant community here in New York City. Hepatitis C is the largest cause of liver cancer in the U.S. Here it's just about 50%. It's our single biggest one over the first 5,000 or so patients that we've taken care of here with liver cancer. But you can see we have this substantial group with hepatitis B because our Asian immigrant community, somewhere around 1 million in the New York area, and among the Chinese and Korean immigrant populations, both a rate of somewhere 15 to 20% hepatitis B surface antigen positive, which means they have chronic infection with hepatitis B. And it's actually hepatitis B, not hepatitis C, that is why liver cancer is actually the second leading cause of death from cancer around the world among all types of cancer. It just rose from number 3 to number 2 in this last year's statistics. So knowing who gets liver cancer makes it an ideal situation for screening. We have ways to look for these tumors, just like women over 50, men and women over 50 get colonoscopies. Women past 40 have mammographies. People with liver disease, hepatitis C, once you're getting close to cirrhosis, once hepatitis B, even without cirrhosis, past age 40 for men, age 50 for women, the risk of cancer starts to go up enough that it pays to actually do imaging tests periodically, and it's been really well established that the right interval is every 6 months. It doesn't matter how high your chances are of getting it. Once you reach the threshold where you should go for screening, which is the first test, and then following that with what we call surveillance, every 6 months is the interval. The idea is to find these tumors at a stage before they cause symptoms, where there's the potential for intervention and in many cases cure. Basically, when a person comes with symptoms due to liver cancer, it's an exceptional case where anything can be done other than maybe some prolongation of survival with medications, but no hope for cure. So this is where we start out, and my role as a surgeon depends on this. It varies in our community. Our Asian community actually is extremely well organized. The surveillance programs of the gastroenterologists in the community, of the health centers, Charles Wang, for example, they do an excellent job screening and doing surveillance of these patients. So we find a lot of patients at an early stage. There's a lot of discussion about how this should be done. What's the best test? Guidelines, which are based primarily on information developed in Asia and Europe, have led to the recommendation that ultrasound is the way to do this. And certainly from the standpoint of the expense of the exams, ultrasound is far less expensive than the alternatives of CT scan or MRI. Its sensitivity is lower, though. About 30% of the tumors will be missed on ultrasound, so that in New York, there are other issues. People who are heavy, you can't see as well with ultrasound, and that's not such an unusual thing in our setting compared to in an Asian setting, let's say in Japan, where this is best developed. So actually at many centers where finding tumors early is extremely important, where we have the ability to do transplantation and surgery, we rely on MRI or CT scanning increasingly because the risks of radiation associated with CT scan have come out. We rely more and more on MRI. Our radiologists are actually developing new protocols to do a rapid MRI in a fraction of the time that a full MRI takes, which would also mean it would be a fraction of the cost, to see if we can compete with ultrasound that way. But this is where it all starts, and I think this is the message that we have to get out through the American Liver Foundation, among others, that people who have cirrhosis for any reason, doesn't matter whether it's alcohol, hepatitis C, primary biliary cirrhosis, primary sclerosing cholangitis, if you have cirrhosis, you're prone to liver cancer, the risk with hepatitis C and cirrhosis about 3 to 4% every year, which means over a 10-year period, 30–40% chance you're going to get liver cancer. Hepatitis B is more or less the same. Fatty liver disease is rising up as a cause, so that people who have cirrhosis need to go for this screening and surveillance. And that may be the biggest message I want to leave for tonight. Unlike most cancers, where the diagnosis of cancer depends on a biopsy, that's not the case with liver cancer. There have been very well-established criteria that are accepted around the world by all the major societies, so that when we have a person who has liver disease, who has a scan, either a CT scan or an MRI that has the characteristic features, then we can make the diagnosis that way. We do see a lot of people coming with biopsies that have been done by well-meaning doctors. Sometimes they can be misleading because actually seeing a scan in this setting that shows a typical cancer is more reliable than a biopsy, which itself can have false readings. It can miss the tumor and it's subject to a pathologist's interpretation. So there are cases where you can't be sure. Of course, biopsy has a role, and increasingly, if we make it to my last slide, we may see that biopsy is taking on new importance as we're developing what we call personalized medical approaches to tumors. Rather than saying, oh, this person has liver cancer, we have to say, oh, this person's liver cancer has the molecular pathway that's associated with increased blood vessel development, angiogenesis increase, and that's what's driving the tumor. And so you may want to take a biopsy and analyze the person's tumor in order to decide the best among our very large and growing number of new drugs. So biopsy is changing, but it's not something we need to do to diagnose liver cancer. At Mount Sinai, we see somewhere around 400 new patients a year with liver cancer. We're probably, as far as we can tell, the busiest center in the United States seeing liver cancer. And this is the way it divides up for us. I didn't tally up, I'm a little late doing this, figuring the numbers for 2013, but in 2012, you could see that among the various treatment options, this is resection, and these are patients who were referred to consider a liver transplant. So a little over a quarter had surgery to remove the part of the liver that contains the tumor. That's resection. And a little over a quarter were sent to be considered for a liver transplant. Now, of course, if somebody needs a liver operation or a resection and we want to do it, we call the operating room, book the case, and a week later we do the surgery. The trouble with the transplant is that organs are not something that are available readily. Some people have a living donor, and we can use living donors to do these transplants, but the weight involved leads to this issue that some patients drop out, which means we start wanting them to do a transplant, we put them on the list, but before they get a liver, something happens. Either the liver fails or the tumor grows in a way that it's no longer reasonable to do a transplant. And of the people seen in that year, by the end of the year, 33 were still waiting, and it was unsure whether they'd get a liver or drop out. But what you can see from this is that somewhere around 60% altogether of the patients we see at Mount Sinai are eligible for treatment by somebody like me, by a surgeon, for potentially curative treatments. This is far higher than the national average, where it's about 20 to 25% of patients with liver cancer are discovered at a point where they can possibly have treatment that could cure the situation. We're not as good as Japan, which is the best. About 75% of the patients in Japan, because they have a nationally organized screening and surveillance program that does a fantastic job. They lead the world in this regard, but at our center, we're doing pretty well. resection, removing the part of the liver that contains the tumor, is generally considered, look in any book, any literature about this disease, to be the first line treatment. That's what you do when you can. But as the surgeon who does this, I'm the first to acknowledge that it's not a perfect treatment for this disease. Everybody who has liver cancer, well, I shouldn't say that, there's a small minority, maybe 10%, who don't have liver disease. And for them, surgery is clearly the straightforward answer. But the large majority has liver disease. Liver disease doesn't affect just the part of the liver that has the cancer. It affects the entire liver. Some people ask sometimes, well, which part of my liver has the cirrhosis? It's not like that. It's something that affects the entire liver. And the liver, you probably know, has the ability to regenerate. It's not like a worm. It's not like you take off a part and that part grows back. But if you take off part of the liver, then what you leave behind will grow until it is to the point where it has the same amount of liver tissue that you started out with. It's not like the left part of the liver does one thing and the right part does something else. You just need the right amount of liver. But when the liver has liver disease, especially cirrhosis, that doesn't happen so fast and it doesn't happen so completely. So we have to be careful doing liver surgery in people who have cirrhosis. And the other issue is, why do they have the liver cancer? Because they have cirrhosis. The rest of the liver has cirrhosis too, and new tumors can develop, and they do. 3 to 4% per year, we just said, with hepatitis C. And if you already had liver cancer, you're probably at a higher risk than that. So it's not perfect, and in fact, if we look at the statistics, which we'll do, you'll see that more than half the people who have this type of surgery show up with another tumor within 5 years. And showing up with another tumor doesn't mean you die. I mean, the survival depends not only, in fact, maybe not most, on what we do with that first tumor, especially the ones that are found early, but how well we follow up people, what we do with the subsequent tumors, and what we'll get to by the end, and Doug will probably play into this discussion, is dealing with the underlying disease. The earlier the tumors are found, the more important treating the underlying disease is in determining the overall outcome. And thank God, after all these years, and you'll see results that I'll show you that I think I look forward to calling historical results. The results of trying to treat liver cancer with hepatitis C in the background have not been fantastic. Now we can cure hepatitis C for really the first time in substantial proportions of patients. So I think that I'm looking forward to these slides rapidly becoming obsolete. Liver transplantation is the alternative surgical treatment for early cancer, and people with early stage cancer, and the staging of this, we won't go into all the details of staging, but a friend of ours named Vincenzo Mazzaferro, who's a surgeon in Milan, Italy, published a paper back in 1996. When we started our liver transplant program at Mount Sinai, actually having a tumor in the liver was considered a contraindication. That means if you have a liver tumor, you can't have a transplant. Because through the early years of liver transplantation, a lot of the surgeries were done for people who had advanced liver cancer. Nothing else could be done, so I said, oh, what the heck, let's do a transplant. And it became clear that the results of those transplants were terrible. And so that I remember very well, it was in 1988, we did our first transplant, we discussed this, we had a moratorium, we didn't do any cases with tumors. But in 1996, Vincenzo Mazzaferro in Milan published a paper where he selected early cases. What he defined that as is if you had one tumor in the liver, it had to be less than 5 centimeters, 2.5 centimeters an inch, that's like a 2-inch tumor. If you had more than that, if you had 2 or 3 tumors, you could still get a transplant as long as none of them were bigger than 1.5 inches, 3 centimeters. And with those limits, he was able to show that the results of transplants for people with cancer were the same as the results for people without cancer. So it hit them out, and it grew to the point where at Mount Sinai last year, 60% of the transplants that were done in people who had liver cancer. Because priority is given on the waiting list for people who have liver cancer. And what does that mean? We'll talk about it a little more, but it doesn't mean you just go get your liver. It still takes, depending on your blood type, up to 1.5 years to get a liver, even with the priority. But the fact that we have this system in the United States has led a lot of programs, especially in places where livers are more available, to push a lot of patients towards transplant rather than dealing with the resection, which is a technically pretty challenging thing. You have to work to develop a program like that. It's not just like you can start up and any surgeon can do it. So how do we know who we can do resection on? What we really have to do is to examine the liver status very carefully. I guess the most common way of judging the severity of cirrhosis is by a simple system first made up by a surgeon named Dr. Childs many years ago to judge the risk of surgery that they used to do for people who had advanced liver disease and had what are called varices, big swollen veins surrounding the stomach that would tend to bleed. And so that they would do operations called shunts to divert the blood away from the stomach. And he analyzed the results of that type of surgery and came up with what's called the Childs class, which just looks at 5 simple things. Whether the person has ascites, that's fluid buildup in the belly, whether there's any sign of encephalopathy, which is the brain not functioning properly because of toxic buildup from the liver. You get sort of, at first maybe just a little confusion, a little drowsiness. Doctors are trained to look for that. And then 3 blood tests, the albumin level. Albumin is a protein in the blood that's sort of a measure of the liver's ability to make things, because the liver makes albumin. The bilirubin level, when the bilirubin is very high, you have jaundice. It's a waste product from the body that's cleared by the liver, so the liver's detoxifying ability is measured by the bilirubin. And then the prothrombin time, which is how long it takes the blood to clot, which is another measure of the liver's ability to produce, because the liver produces the factors that clot the blood. And using the results of those tests, you can judge a patient to be in class A, B, or C. Class A means that all those things are normal. And only people with class A cirrhosis, Child's class A, are eligible for resection. Anybody else, you try to do resection, things are going to fall apart, you're not going to get good results. And the other thing that happens as a result of cirrhosis is what's called portal hypertension. Cirrhosis means scar tissue built up in the liver. And the liver has 2 sources of blood coming in. An artery, like every part of the body, and then a vein, the portal vein, which brings actually most of the blood to the liver. But the portal vein is like any other vein. It's not under high pressure. The pressure in the portal vein is pretty low, and the scar tissue building up in the liver can start to choke off that flow, so that the pressure starts to build up in the portal vein, the spleen enlarges, the platelets go low. And if that has started to happen, even though the liver function may be pretty good, maybe Child's class A, still surgery is not good. And the easy way we have to judge whether there's portal hypertension is to look at the platelet count. Platelets are little particles that clot the blood, but when the spleen starts to get big, which happens when the pressure starts to go up in that vein, the spleen traps the platelet count goes low, and so that if the platelet count is below 100,000, as long as the person has a spleen, we can use that as a reliable index. If the patient has their spleen out and the platelet count is normal, then we still have to worry because it may be a false reading. There are major differences depending on the underlying liver disease. What we see here is that people with hepatitis C, the green, are much more likely to have a transplant, twice as likely to have a transplant compared to a resection, whereas people with hepatitis B are 3 times as likely to have resection as they are transplant. This is our own information from Mount Sinai, and it's because we apply the same criteria to everybody, the same measures of liver function, the same measures of the tumor. People with hepatitis B tend to have better liver function than people with hepatitis C. They're very different conditions. If we look at the patients that we've done resections on, this is a little over just past 1,000, you can see that almost half of them have hepatitis B. Hepatitis B patients, which are for the most part are Asian patients, have excellent liver function and are excellent candidates for surgery to remove parts of the liver. And what we see is that the results in the patients with hepatitis B are much better as well. This is our overall patients with hepatitis B and liver cancer compared to hepatitis C. You can see that the difference is obvious, and when we do statistical analysis, it's significant, which means that the chances are considerably less than 1 out of 20 that they could actually be the same. If we look at just people who have early tumors, these are tumors, one tumor less than 5 centimeters. In other words, the people who would be eligible to have a transplant, the results of hepatitis B, 5-year survival are about 76, 77% 5-year survival. Excellent results. The results with hepatitis C are not as good, and it's because people with hepatitis C have deterioration of the liver, but they also have a higher likelihood of recurrence of cancer. We've seen this very clearly. When it comes to transplant, it's like the flip side of the coin. You can see that the large majority of the people have hepatitis C because they're the ones who have the worst liver function. Now, if we look at cancer coming back, the green line is cancer coming back after resection. This is the time that goes by, and this is how many people have recurrence. And you can see by the time even 3 years go by, it's up in the 60% range of people have recurrence of cancer. After transplant, because we restrict to those early criteria, we remove the whole liver, they don't have cirrhosis anymore, they can't develop new tumors. The only way a tumor can come back is if a cell got away from the old one before the transplant and then grows up afterwards. The likelihood of recurrence is far less. So you might look at this and wonder, why would this guy be up there talking about doing resection? Who would want to have a resection? And the answer is fairly straightforward. These are the survival results of transplant, comparing the results of hepatitis B patients who had tumors that were transplanted and hepatitis C patients. And doesn't that look an awful lot like the slide? This is the resection slide. This is the transplant slide. The two are almost identical. The hepatitis B patients do better than the hepatitis C patients with transplant, just like with resection. Here, it's not because they have higher recurrence, it's because hepatitis C has always, over the years, come back, attacked the new transplant, and degraded the results. That's been our problem. We've analyzed this here because it's a controversy out there. I speak around the world on this topic because we have a unique situation here at Mount Sinai where we have large numbers of people with both hepatitis B and hepatitis C. For the most part, the statistics from hepatitis B cancer come from Asia. The statistics from hepatitis C come from Europe and the US, and everybody says you can't compare them because they do so many things different in one place from the other. But here in Mount Sinai, we have both. We've been able to do this comparison. So what we see here is people with hepatitis C who have a single tumor less than 5 centimeters, they would be eligible for a transplant with a priority, or they could have a resection, comparing our results. And you can see that the green line, which is the resection, the blue line, almost overlap completely. There's no advantage to one over the other. They die for different reasons, but they die at the same rate. The trouble is with the transplants, that not everybody we put on the transplant list gets a transplant. So that if you want to do a real fair analysis, you have to do what we call an intention to treat analysis, which means you have to start counting from when you decide to do the resection, which is about a week before you do the resection, as compared to when you decide to do the transplant, which may be a year before you actually do the transplant. So you have to include those patients who drop out. And when you do that, this is the rate what we see with dropout at Mount Sinai. Over a year's time, those people who initially met the criteria for a transplant, but who had 2 or 3 tumors, as you remember, it's 1 tumor less than 5 or 2 or 3 less than 3. The people who have 2 or 3, the people who have a single tumor more than 3.5, are the ones who have high tumor markers. There are things we can measure in the blood produced by these tumors that give us an indication of how aggressive the tumor is. Those patients have a high chance of dropout. At 1 year, about 40% chance. And you can see how this line is more jagged than this one. That means that more patients are on this line. So if you figure that in, these are our results, our actual results from Mount Sinai, comparing resection to transplant, intention to treat from when they were put on the list. The results are actually significantly better with resection. That's why we continue to do resection. If we had livers available for everybody, and we were back looking like this, more or less equal, I would still do the resection, because a transplant is a major undertaking that leaves the person with the need for lifelong immune suppression. I mean, don't get me wrong, I ran the transplant program here for many years. I'm a big fan. I do the transplants. It's one of the most fantastic developments in medicine, but if you can treat things in another way, it's something you should try to do.